All right. So I'm delighted to be joined by some colleagues from around LMU to talk about the coronavirus and the COVID-19 pandemic that we're living through. My name is Rachel Washburn. I'm an associate professor in the Department of Sociology and head of the new Health and Society program. And we decided that it might be helpful for students, for faculty, for the LMU community, and potentially others to convene a panel where we talk about how each of us who study health, but through different disciplinary lenses, are thinking about this current pandemic. So before we get started with our panel discussion, I'm just going to introduce our panelists. So we've got Dr. Carla Biddle, an associate professor in the Department of History, Merid Sullivan, as assistant professor of women and gender studies, and Ash Kelly, associate professor in economics, and Katie Mouzakis, an assistant professor in chemistry and biochemistry. So thank you very much, all of you, for taking time this morning, April 15th to mid-April here. We're a little bit more than a month into sort of the lockdown in LA or all of the changes that have happened in Los Angeles and California. So I'm going to go ahead and pass the mic over to Dr. Carla Biddle. And just to sort of start us off, maybe, Carla, you could talk about, as a historian, some of the things that you've been thinking about over the last number of weeks here. Obviously, we saw the first case of COVID-19 in the United States in late January. So it's been a couple of months now, but certainly over the last month or so, things have really ramped up. And I'm sure over that time frame, you've been thinking about a number of things as a historian of science and medicine.
Thanks, Rachel. I'm really glad to be here. And the funny thing is I've been thinking about, the history of disease for 20 years and the history of epidemics and pandemics. And now to have this one so immediate is really interesting. And it raises a lot of important historical questions, I think, and of course, contemporary issues. And I look forward to talking with everyone about that. As a historian, I'm interested in several things. I'm interested in, the inseparability of science and social context. And in that way, the production of knowledge about this virus. I'm interested in how do we know what we know, and who is producing the knowledge, and how that knowledge is changing. So that's one, large area that I'm interested in tracking. I, in some ways, consider myself a historian of knowledge too. So and so what I mean by that is science, but also other ways of knowing in society, in different societies about epidemics. I'm interested in the sources, so the primary sources, and how will historians study this this pandemic someday or soon. What is the archive for this event? What is the material history? What are the things that are present or that are missing, and in daily life, but then also in how do we study digital life in this time? I'm interested in historical memory, and how we remember past histories of disease and epidemics, or don't remember them, and why. I'll talk about 1918, I'm sure, during this conversation, but there was a lot of amnesia around 1918 for a very long time. And so I'm interested in historical memory and why that's the case, and why things become remembered and useful to understand at different times. I'm also interested in the immediacy and visibility, especially how that happens, how that seems to be happening right now, the way in which this has become the most immediate issue of our time, but also to think about then what gets left behind and what the silences are, and the issues of chronic illness, right, that are underlying a lot of this, and we can see that historically too. And I hope I'll be able to talk about certainly continuities and parallels with the 1918 pandemic, but also, differences and other pandemics or epidemics we can turn to for, you know, information and to think about is historically comparative. And you know, again, I think that 1918 is really useful right now. It's important to recognize those parallels, and at the same time, I also think we need to recognize that it's becoming the lesson. Somehow, and I think we should, you know, talk about why that is, and also kind of critically analyze what is useful about that history. So that's how I'm approaching it as a historian, and I look forward to hearing everyone else talk about it. And with that, I'll turn it over to Ines, and she'll talk about it as a health economist.
Okay, thank you, Carla. I'm going to share my screen. That's okay, if everyone can see this. So I think health economists especially, but economists in general, are looking at the lack of random testing as, surrounding COVID right now, COVID-19, as the biggest policy failure, because with random testing, we could actually help you know, do targeted social distancing and have policies that would be more effectively reduce the severity of the recession. So I think it's inevitable that we're facing a recession, but it might not be as bad as we think, and it'll especially be much better if we extend testing. So that's been probably the biggest policy failure. Obviously, there were problems with our fragmented healthcare system before all this, but especially in the United States, this might be another obstacle, and that's another concern that health economists have. Obviously, we have an overwhelmed healthcare system, capacity constraints, no vaccine yet. And I guess if we want any kind of herd immunity to work, we do need a vaccine, and that's much further in the future. Economists like to think of externalities, so negative spillover effects. And the problem with not having severe containment measures is that people aren't going to behave in a way that's socially optimal. And so there's this huge negative externality, which is why we need containment measures. There's some hope that the epidemiological models that we currently see actually will probably overestimate the severity, because, you know, economists look at behavioral response as being endogenized. Well, people respond even before the containment measures. People were changing their behaviors in response to this news. They were washing their hands more. They were using sanitizer, and so the severity isn't going to be quite as bad. Now, as a health economist myself, I'm more of a demand side health. I look at behaviors. So the direct, obviously, concerns that health economists have are capacity constraints, healthcare resources, you know, not enough hospital beds, ventilators, protective equipment, and so no, we're not prepared for the onslaught of cases that would occur if we didn't take part in this in these quarantine measures. And so I'm thinking of also some indirect consequences. So I'm thinking of the mental health concerns associated with staying at home. That was one of the first concerns I had. So we're social creatures, and just staying at home is going to have its own mental health problems. There are going to be physical health concerns. So this is unrelated to the coronavirus. People are putting off wellness visits, or putting off going just to see a doctor if something's wrong, because, you know, for obvious reasons. And so that's going to have unintended consequences in the future. That's one thing that I'm thinking about as a health economist. Now, economists in general obviously are worried about the economy. I know everybody is, and everybody is affected by this. So there's an inevitable trade-off, and economists are always looking at trade-offs, right? The severity of the recession versus the health consequences of the epidemic. There have been several studies already out showing that what we're doing, you know, containment early, strong containment, right, severe containment early on is the best policy response, and that'll minimize the effects of the recession later on. So yes, it'll bring economic activity to a near halt, but these large scale containment measures which will lead to this drop in aggregate output, is going to save roughly 500,000 lives. So there's been this, by Muriel Jacobson and Tom Chang, this economic rationale for strong action now. So if we did absolutely nothing, if we, and so if we did absolutely nothing, and taking into account, so the elderly especially would be hit hard, but taking into account the quality of a statistical life, the economic cost would be just under half of US GDP. And so we realize why we have to, and doesn't even take into account, the cost of those who get sick but don't die, lost productivity, or direct medical expenditure. So it doesn't even take that into account, which would make it probably over half of GDP. So we can see why we're taking these extreme measures so fast. Now, I think and these are all from very recent studies. I don't put the date because they're all from March or April of this year. I like this graph because it shows this is kind of what we're doing. We're not really testing extensively, and so we're having quarantine, and those who are infected, full quarantine. But the severity of the recession would be much less if we had extensive testing. Then we could release those who are into the economy, release those who are recovered or not infected, and then have a full quarantine for those who are infected, and that would be a much better and more targeted policy, which is why testing is one of is so important. Sorry, and oops, sorry. Now, just as an example, and one I guess maybe problem with the United States is we're so heterogeneous, right? States are going to be very different from one another and respond very differently. There's already been some preliminary evidence that what California has done here. So here in California, we had a stay-at-home order. So the CPO, shelter-in-place order, starting March 19th, and this was before any other state. So this order was before any other state, and already we see that. So one study suggested that we've potentially prevented up to almost 5,000 COVID-related deaths because of this, just here in California. So you can, if you compare it to other states, so here in California, we started in 3/19, and for example, New York started March 22nd, but they were already up here, and because it's so contagious, it just skyrocketed there. So starting early really did make a difference. And this is just showing, so by state, the COVID cases, but what's more relevant is taking population into account, and you can see California, and it's important for California considering it's the largest economy in the United States. And already the governor is talking about measures, what we're going to do when we go back. Now, of course, it's going to be gradual when we go back, mentioning things like continuing social distancing, having disposable menus, things like that. But he is already talking about what is going to happen when we return. Now, I'm also concerned about groups that are disproportionately affected. And this is, so the recovery isn't going to happen for everyone equally. And those already disproportionately affected both by the virus and by the economy are those low socioeconomic status, low income, low levels of education, minorities, females. So these are all, studies have looked at these already. Those with little internet access or fewer technological resources, so the digital divide, and also independent contractors and those in the gig economy who might find it hard, find it hard, especially to get unemployment benefits, at least right away. I know they're doing something to address this, and policy response is going to play a big role and is going to be very important in all this. So only about 37% of US jobs can plausibly be performed at home, and those are going to be performed generally by those with higher incomes, and again, higher levels of education. So again, those vulnerable groups aren't in this percentage. So we're looking at high unemployment rates, possibly up to 20%. But and you could see just here, weekly economic indicators show, right? down, down in terms of spending. What's happened, right? It's gone down across the board recently. But the good news is that, people aren't doing this because, by choice, right? So once this all comes back, and people, I think, are hoping for a V-shaped recession, so a plunge down, but then, the more optimistic, we're looking at a good recovery. So I think there's a consensus among economists. It's quite optimistic in some ways, considering we are going to be facing a severe recession, but it's not a repeat of the Great Depression. So government responses can make a difference. The CARES Act, Main Street Lending Program, and so on. Bailout, as of just yesterday, we heard that there was an agreement with the major airlines. And I think I'll end it with this slide, which I think is somewhat optimistic. So here's what's happening with the virus, but here's what's happening with the economy and GDP loss. And yes, with the containment policies, which we all agree are necessary. The severe containment policies are necessary considering the parameters of the virus. There's, right, the green line shows how it won't be so bad with a good and effective economic policy. And with this, I'd like to turn it over to Merid, who's thinking about the social context and the cultural impact of the virus.
Excellent. Thanks, Carla. Thanks, Inez. So I am a critical health scholar. I'd really situate my work in thinking about the ways in which the dawn of the AIDS crisis in the US in the 1980s, and specifically queer and feminist and anti-racist activism that grew out of that moment, how that's shaped and shifted other ways that we think about health and disease in our society. So for me specifically, I think about how these moments shifted how we think about breast cancer and the ways in which breast cancer activists worked and mobilized with HIV activists in thinking about compassionate use access and drug development and the sort of democratization of science. And of course, for ACT UP and those activists, they were building off of a rich history of the democratization of science, really rooted in the Black Panther Party and the revolutionary moments of the 60s and 70s. And my next project is thinking about the ways in which these histories have shaped narratives around herpes and the herpes simplex virus. And so that might be one place to start in thinking about there's a number of ways that I'm thinking about this current crisis. And I want to actually pause to give thanks to my students who have very enthusiastically taken on shifting all of our coursework to thinking within this moment. And they've helped me to be processing and thinking about this moment and what we need to be thinking of as anti-racist and feminist scholars. So a lot of what I do in my work is think about narratives. And there's two specific narratives that I'm paying attention to right now. One is the way in which statistics is a kind of narrative device. And I think building on Inez's point about testing and the need for more testing, since March 4th, I have been every day marking the numbers, sort of creating my own epidemiological map. And I was recently, I've been recently asked by more like friends, not in any professional capacity, to sort of anticipate how the numbers will rise across the next weeks in the United States. And what is not apparent, even though this is clear if you read the news, is that we do not have for a variety of reasons, we do not have the capacity to be testing in all of the ways that we should. And so our denominator for this statistic is much smaller. So for me, I've been paying attention to what's going on in Germany. And it's only in the last 48 hours that I've recognized that Germany has instituted widespread testing. So you'll see that their fatality rates are much, much lower than other countries, especially other developed countries. But that is not necessarily because the disease is progressing or being fought any differently in Germany. It's rather that they are instituting such widespread testing. I think that in my classes, we frame everything as things that are not necessarily good or bad, but everything is dangerous. And we sit here in this moment in which thinking about widespread testing is both absolutely necessary for containing and understanding this virus, and it is the gold standard of epidemiological work. And also, many of the technologies that will emerge in order to track testing risk reproducing and building on the ways in which differences are already marked as social differences, right? And so one of the things that I've been paying a lot of attention to is the ways in which those who are already most vulnerable and most marginalized in our society are disproportionately affected by this virus. And I see a number of interesting narrative shifts there. One thing that I've been paying attention to is the way in which the virus is being marked as as having agency. And just this week, the New York Times read a headline saying virus preys on disabled adults in institutional homes in New York. And what this does is it creates a narrative that there's something within the body of disabled adults or within the bodies of people of color that makes them more susceptible to the disease or to the virus, and that somehow the virus is targeting these susceptibilities. Whereas what we know is that it is in fact the social conditions of people with disabilities, the social conditions of people of color that mark them as already more vulnerable to the virus and already less protected by a number of social structures. And so, Inez, when you talk about the need for widespread testing, one of the things that we see coming out of the stimulus packages is the necessity to make sure that that testing is available and that people will not be punished through like loss of income, et cetera, that people will be protected when they do in fact receive a positive test. But these conversations, I think, need to go even further, because without guarantees of better healthcare across the board, we already know that people with pre-existing conditions, most of which things like high blood pressure, diabetes, et cetera, these are diseases that are connected to social stressors and to lack of access to resources. And so without dealing with those root problems, we are still going to see, despite testing, despite access to testing, and even access to coronavirus treatment or to COVID treatment, without addressing these root causes of health disparities, which are intimately connected to economic disparities, we won't actually see a shifting narrative or shifting outcomes around this disease. And so the final narrative that I want to point out too is the way in which, 6 months ago, the way in which we, under our current economic system, have this concept of skilled versus unskilled labor, right? And so one of the things that my students and I have been doing in our class is tracing histories of quarantine and the ways in which quarantine was often mandated for people who are already in marginalized or economically compromised positions as a way to sort of contain and remove. Whereas now we're seeing quarantine as something that is only available to those of us who have the class privilege to actually contain and remove ourselves. And so jobs that even 6 weeks ago would have been called unskilled jobs, grocery workers, long haul truckers, even, janitorial staff at hospitals, et cetera. All of these jobs are now considered essential workers. And so one of the things that I'm looking towards is how do we pick up on that narrative? How do we both resist the narratives that the virus somehow has some sort of agency that disproportionately targets people, whereas we know that it's actually about a disproportionate vulnerability to these kinds of social collapse and to disease without proper economic stability and healthcare, but also how can we hang on to this moment of recognizing the essential workers of our economy and of our society and continuing to value them through economic means and through social valuation going forward. So finally, one of the things I'm thinking about too is this history of vaccine development, because as we know, AIDS activists in the 1980s really shifted the ways in which they demanded public access to knowledge and to scientific conversations and to having patients and those most affected by diseases at the table when the FDA and other organizations are making decisions about treatment. And so I guess with that, I'll pass it over to Katie with questions about how do we think about this virus? Like, what is a virus? What does it mean to make a vaccine for a virus? How come, honestly, one of my questions is why do we think there will be a coronavirus vaccine within a year when we still don't have a vaccine for HIV, for HSV, for a number of other viruses?
Yeah, that's an excellent question. So hi again, I want to thank everyone for allowing me to be part of this panel. It's been really exciting to hear everyone's perspective and think about the bigger picture of the actual coronavirus pandemic. As a biochemist who studies viral RNA structures, and very intimately involved in the science and understanding of how viruses actually replicate. And as sort of a response to being put in this situation of quarantine and having this pandemic, my initial approach was to learn as much as humanly possible about the science of the virus. And I'm more than happy to share what I know. And I think I'm going to address Myriad's question, and then I can talk sort of bigger picture about the things I'm thinking about, and sort of field other questions as we go through this, because it's a little deeper into the virology, but it should hopefully be accessible. So a virus is considered to be a non-living particle that can only replicate inside of a host. So I can show you, I'm going to pull up a set of slides real quick. At LMU last fall, I taught Introduction to Virology course for the first time. And so it's been actually quite exciting to communicate with the students who have been in that class through the whole course of when this has been happening this semester, and also share that knowledge with others at LMU. So let me just pull up a slide real quick. Okay. Okay, let's see. And I think, which view are you guys seeing? Sorry.
Screen.
The presenter mode or the full screen?
Full screen.
Oh, good. Okay. So viruses are considered infectious obligate intracellular parasites. And here are a bunch of like cartoons of different viral structures. The one down in the bottom is the cartoon of the coronavirus, which has little spikes, right? This like corona or crown-like structure. But all viruses are these, can be considered these little particles that have the ability to enter certain cells. And then if it can replicate within a cell, what that means is it's making more copies of itself. But the virus is not, as Mary was suggesting, it's not trying to do this, it just can do this. So it's when viruses infect a cell, they make more copies of themselves using host resources. And that's why they're considered this like parasite, is just because they're relying upon resources they don't bring with them. But not all viruses necessarily cause disease. Clearly the coronavirus we've been talking about does. And this virus in particular is what we call an emerging infectious disease. So it is emerging because it recently entered the human population. The scientific evidence suggests that it originated in bats, as far as we can tell, but there may have been an intermediate host. And all that means is that if this virus had been sort of propagating inside bats, not necessarily causing the bats any harm, so they were sort of coexisting, then if that virus jumped, it could either have jumped from a bat to humans, or from a bat to another animal or species, and then to humans. And that's called zoonotic transmission. And the reason we know this is because scientists were able to sequence the full-length genome of the coronavirus, the SARS-CoV-2, and compare that sequence to other viral sequences that are publicly available. And lucky for us, we have people who study viruses in all kinds of animals. So we have information on viruses that are typically found in bats. And so you can do this comparison. But yeah, in terms of getting back to Mary's original question about vaccine development and why there is hope maybe for this happening quickly relative to other vaccine programs, I think, with any vaccine, what we're trying to do is develop something that can be given to an individual in a safe manner that would initiate an immune response to that agent that then gives that individual protective immunity from future exposure. And so I have another set of another picture I'd like to show that relates to vaccine development and we can also talk about like herd immunity and what that means at the same time as we do that. So let me just grab that. Okay, so the goal with a vaccine is that you are exposing yourself, or you're exposing yourself to an item that can give you protective immunity in the future when you're actually exposed to this causative agent or this coronavirus. And vaccines are developed in a multitude of ways, and they're not actually live virus typically for the most part. The reason they take so long to develop and go through several phases of clinical trials is because we have to make sure they're safe. So if you're giving a vaccine to someone, it must not cause any disease. And the idea is when you treat someone with a vaccine or you get vaccinated, you have an initial immune response that then leads to long-term protective immunity, and we call this memory. And this is relating to like your B cells that can release antibodies into your bloodstream if you're ever exposed to the virus. And when those antibodies are released into the bloodstream, they would coat the virus effectively, and then that can get destroyed. So an infection is when the virus has been able to enter your cells and replicate. And so if you can stop the virus before it can enter your cells, you avoid infection. And the reason this is critical is because while there are many types of infections you can have, if you can avoid an infection that results in disease, can save a lot of people. And so with a vaccine, the idea is we're building up immune memory in the absence of any disease. And in the case of the coronavirus, what we think is going on, so if we look at this table, we have a timeline of virus production. So this would be equivalent to like what we're thinking about with viral load that you're hearing about in the news. And when you're initially infected, it's low, and then it's making more copies of itself, or more copies of itself are being made in your body, and so it goes up. And at some stage, this can be associated with disease. And for some people, right, this virus has we're seeing a wide range of severity of diseases. And I think especially thinking about the groups we've been talking about too, who have been disproportionately affected, it's not because they're more susceptible to infection. It's because the conditions they're already dealing with that have been associated with those, or like sort of forced upon those groups in these different socioeconomic populations, makes effectively their immune response less able to handle or clear the coronavirus infection. So we think that the wide range in disease severity really relates to, relates to how each individual's immune response is handling an infection and trying to fight off that viral infection. And the disease associated with the coronavirus infection, the COVID-19, appears to be in large part the real severe cases are a result of sort of almost potentially an over-aggressive immune response or an ineffective immune response. And so for those who do recover, the viral load should go down, and theoretically they would not have disease. And then the goal, right, with a vaccine is to not have this happen at all. So if we go back to this slide, if you vaccinate someone, then when your immune response kicks in, if you are exposed, it would clear that virus right away before infection. And now I think it's really interesting too to consider, I'm gonna just stop sharing this slide so we can go back to our big discussion, to think about why we don't have vaccines for all of these viral infections that we know about. Like we have some, right, and they're fantastic. The measles vaccine, smallpox vaccine, right? Smallpox has basically been almost entirely eradicated. And I think for certain diseases like HIV/AIDS in particular, with HIV, we've gotten to a position where we have enough antiviral drugs that people can, the disease has gone from basically a death sentence to a chronic, right? A chronic manageable disease if you have the resources for, right? Which is not fair. But if you have the resources, it can be a chronic disease. And so that while there is active work on developing vaccines, one of the biggest challenges with vaccine development is it's a very like high risk economic challenge for companies. So it can cost millions of dollars to potentially develop a vaccine. I think even potentially on the orders getting very high, and it can fail. And the reason it can fail is because in order to get that like appropriate immune response in your body that would give you immunity to something that's long lasting, meaning you could have the vaccine once and have immunity for years, is not obvious. So how our immune systems work in response to different viruses can be very different, and what type, if you need like a specific B cell or T cell, or there's a lot of factors that are not obvious. And I think the other challenge is if there's not an economic market for the vaccine. So I'd be really interested too to hear about what Ina thinks about this. So a lot of conversations about vaccine development for things like emerging infectious diseases, and especially thinking about SARS-CoV-2 as it's very similar to the SARS coronavirus from 2003. And it's different, like the sequence is about 80% conserved. So that means there's 80% similarity in the sequences, and 20% is different, which is pretty significant. So if you think about like our genetic sequences versus like monkeys, right, we're much more similar than that. So the viruses are pretty different from each other, but they share a lot of the same characteristics and a lot of the same steps that are necessary to make more virus. So if we had continued to study or put resources into the development of a vaccine for SARS, which infected 8,000 people, right, much fewer or much less than we're dealing with right now, we might have been in a position today where we'd be much closer to a vaccine. But the question of the market is, if you spend all this money developing a vaccine, and then let's say for SARS, the pandemic ends and it's not circulating in our population, like who's recovering the cost of development? And I think a lot of what I've been hearing lately, which is really positive, is this sort of global talk from scientists asking for, like, we need a repository, like we need governments investing in vaccine development for emerging infectious diseases and antivirals, even when they're not a threat. And we need we need there to be sort of this market assurance that those companies are not going to go under if they get to a point where the vaccine's been developed and that there's no longer a disease. So I think that the issue is with if you have a disease like HIV/AIDS, where you already have antivirals that can control viral replication, then the economic cost of a company investing in trying to come up with a vaccine, right, that you give to a person and then they're cured, right, they can't get infected, I think it's a really hard market for those companies, and it's scientifically challenging to come up with something that is safe, effective, right? It needs to provide long-term, long-lasting immunity. But I think for this coronavirus outbreak, it's particularly critical because we don't have herd immunity. And so herd immunity it describes the number of people in a population that are immune to the virus, either because they were previously infected and their immune system cleared it and developed this long-term memory, or because you've been vaccinated and now you have long-term memory and immunity to the virus in the absence of infection. And the idea with herd immunity is if you have enough people that are immune, then transmission of the virus drops substantially. And it's really important because we have a significant proportion of our population who can't, right, be immunized. Maybe they're immunocompromised, or for a variety of reasons, it's not safe for them to be infected or to even be vaccinated. So herd immunity is going to be really critical. And in the absence of a vaccine, the only way of getting it is to actually have been infected, which is incredibly dangerous and unethical in a sense too, because you're putting people's lives at risk, because this is very a very deadly disease for a lot of people. So I feel like I've been talking about a lot of different things, and I would like to take some questions from you all if there's something I didn't jump into or follow up on what I've said so far.
I'll just go ahead and jump in here, and let's see if I can change this view. Okay, maybe that works. I'm not sure, but I want to say a little bit about how I've been thinking about coronavirus and COVID-19 as a sociologist. But before I do, Katie, I just have a quick question for you, and then I'll say a few words, and then I've got questions for other folks as well. But in terms of the vaccine, because I know that's been a really big thing that a lot of folks are talking about as, one of the factors that will really allow us to move away from some of the social distancing with more, a sense of more safety.
Mm-hmm.
The estimates that I've heard are sort of early 2021. Is that the timeline that you're aware of? And then also, is there anything about the structure of the virus that makes it more amenable to a vaccine? And I've heard that as well, that there's something about that structure, the crown structure, that actually makes it more amenable to a vaccine than perhaps other viruses out there. So maybe you could just quickly say something about the timeline and then about the structure of the virus that might make it more or less amenable to a vaccine.
Absolutely. So for the timeline, getting a vaccine in 2021 is actually it's super fast. And it's because we're developing vaccines at what is called like pandemic speed. And I recently, for my advanced biochemistry lab course, we're doing like this whole sort of biochemical investigation into this. And so we recently read a paper on vaccine development actually in this context. And I'm going to pull it up real quick because it has like a really excellent figure that I can show that talks about why this would actually be potentially feasible in a short period of time. Okay. So this is from a perspective piece in the New England Journal of Medicine that was published recently. And what we're seeing here is a difference between traditional vaccine development and those used during a pandemic. So usually with traditional development, you have a lot of steps where you evaluate how efficacious the vaccine is, right? Does it work in animals to elicit the immune response that would protect that animal? Then you can move in to small trials in humans looking for safety, and then you look at effectiveness in terms of stopping an infection before it starts actually giving someone immunity, and then you continue evaluating this in human trials over the course of many months and years. And during this time, it takes a while to make sure something's safe. And that is really, really critical that the vaccine is safe. And then what you'll notice on the top paradigm is we see that the scaling up, right, of the production of the actual material that's in the vaccine goes through stages. And the reason it goes through stages is because if you jumped to large scale manufacturing before you made sure it was safe, right, you spend a whole lot of money scaling up production. Now, what we're doing right now and why it is not necessarily unreasonable for us to have a vaccine, I think the estimates I've heard have been maybe like on the order of 18 months, 12 to 18 months is sort of the fastest. The reason that might be possible is because we're doing a lot of things in parallel now rather than waiting to find out the results. And the other thing that's been really exciting is there are multiple vaccines being developed at the same time. So that gives us sort of a better shot of getting to something that can provide immunity. So we're doing the large scale manufacturing and the scaling up at the same time as we're starting to get closer to actual trials. And there's the Moderna vaccine candidate is actually, I believe, in phase 1 clinical trials right now. So we have some that have entered clinical trials, and then there's hope that those will work. In terms of the viral structure and thinking about how that may or may not give us an advantage, I think my perspective has been, it's not necessarily that there's something different about this coronavirus versus the SARS coronavirus, but our advances in basic scientific understanding and our toolbox to determine the actual structure of like the spike protein, and thinking about that's the one on the surface that gives it this little crown appearance, right? If we understand the spike protein from SARS-CoV-2 better because of previous research on other viruses, we have a leg up in terms of developing something. Mm-hmm. And so the Moderna vaccine actually is a lot of the science that behind it came from studying other viruses. And so it was sort of like we have these vaccine candidates now that might, especially with the Moderna one, it's an mRNA-based vaccine. So what this means is it has a piece of RNA that codes for the coronavirus spike protein in a very specified, like three-dimensional structure that would be produced. And so with just this mRNA, right, you can't have an actual infection. You don't have any of the virus's full genetic material. And the hope is that you also would not elicit an immune response that would be harmful in the course of vaccination, right? So your body could tolerate the vaccine really well. And the idea is you introduce this mRNA into some of our own cells, and then those cells make this version of the coronavirus protein, release it into, and it's sort of excreting it into the bloodstream just as a normal consequence of how it's made. And then our body says, oh, there's this foreign protein here. And because of previous research, and because we know we have a good idea of what structure it looks like on the outside of that particle, then the hope is that the antibodies we would develop naturally in a response to that would give us protection. And so it's really, that's giving us, I think, giving us more optimism in terms of developing a vaccine. The other thing that's exciting about structurally about the coronavirus that is a potential target for the vaccine. So in the coronavirus, the spike proteins on the outside, and that's going to be important for actually binding to a receptor and getting into a cell. But the next step, once the virus gets inside a cell, its mRNA is going to be used to create additional molecules of RNA. And it turns out humans and other eukaryotes don't have the type of enzyme that can take mRNA and use it directly to make more mRNA. So the virus brings along a protein called the RNA-dependent RNA polymerase. And the structure of this RNA-dependent RNA polymerase appears to be very similar between this coronavirus and other coronaviruses, as well as other just positive strand RNA viruses. So the hope too is that if we have this really specific target that we don't have in human cells, if you can develop like antivirals or a vaccine that target this specific thing, then that might be more efficacious, or like give us a better chance of success, because we can differentiate between host and the actual virus.
Yeah, great. Okay, well, I'm gonna thank you. You've given us a lot to think about, certainly. I'm gonna go ahead and jump in with a couple thoughts, and then I've got a question or two, but other panelists might also have a question. So again, thanks so much, Katie. So like a lot of you guys, I'm not sure if this is actually on my screen. You're still big, Katie, so I'm gonna go back to just the gallery view, and we'll go with that. Just because of the recording. But as a sociologist, I've been thinking about a lot of the same issues that you guys have been thinking about as well. Probably not so much, Katie, some of those deep sort of structural, viral issues. But I've been thinking about sort of three major things. First, how are we as the United States responding to this threat, and how are different governments responding to the threat, kind of as a reflection of our cultures, and the kinds of public health systems and health systems generally that we've created. But also in terms of cultures, we have a very individualistic culture in the United States, which is part of why our healthcare system looks the way that it does, which is part of why we might be reticent to adopt some of the, surveillance measures that have been enacted in other countries where caseloads are lower and where deaths are much lower. So I've been looking a lot at, sort of just tracking our cases in the United States, knowing, Merit, just as sort of you've raised that, our testing is so bad that those numbers and statistics are really very flawed. I've heard some estimates that say, take whatever we know and times it by 5 or 10, and that probably gives you a more realistic number of the actual cases that you have. And but nevertheless, I've been kind of just, looking every night at the maps and, seeing how those cases are expanding, but also really thinking about, doing comparisons between the United States and other countries to look at that. I've also been really curious about, why caseloads and death rates are lower in some countries than in ours, and thinking about, in particular, South Korea has really stood out, Germany has stood out, but in particular, South Korea, having that experience with SARS, as Katie, you were just talking about, really, I think, shaping the way that they're responding and have responded to this kind of pandemic, and being very aggressive at the outset, but also having a fairly different culture when it comes to their acceptance maybe of surveillance techniques, a lot more aggressive contact tracing and that sort of thing, which really helps us to control the spread. So culture is something I've been thinking a lot about as well. I've also been thinking about something that, both Ines and Merid mentioned in terms of disparities in illness and death, in terms of, who's getting sick and who's dying. And, over the last week or two, that picture has become a lot more clear and vivid. Again, I think data are still being collected and analyzed to really get a portrait of what, these what the trends will look like across groups. And it's kind of mixed. Like in Michigan, it's been really well documented that the folks dying of COVID-19 are disproportionately African-American. In New York City, that picture changes a little bit, and it's disproportionate. Folks who are getting sick and dying are disproportionately Latino and Asian American. And so the picture is different, and in different places, but I think, as Merid, you were mentioning, it all points to underlying vulnerability and underlying susceptibility, which, as somebody who studies health inequalities and teaches about health inequalities, none of it is really surprising. We know that some of the basic drivers, as Merid mentioned, are just social stress, which leads to greater underlying conditions, which leads to greater vulnerability to something like COVID-19. We also know poor access to healthcare is another one. So we still, as many as you all know, but some people who watch this video might know, we still don't have a universal healthcare system in the United States. So we exclude undocumented folks or unauthorized folks from participating in the ACA. So those folks are more vulnerable to not having adequate care, as are many other groups. And folks who are of lower SES status, have a harder time social distancing. They are now considered essential workers, or might live in more crowded conditions, might have to rely on public transit to get, groceries and things like that. And so I think that point about, who are we now viewing as essential workers is a really, really important one. And one that, some farm workers actually are feeling a little frustrated by, in the sense that they have long felt very disposable and now are viewed as absolutely essential, just as many other frontline workers are. So just a couple other thoughts about culture that, again, Merid, you touched on quite well, but I think it really, our response in the United States has been, I think we can all agree, has been pretty bad. Has lagged, has just not been very effective, to date. Obviously, we're trying to catch up and, take measures that we need to in California and many other states. I think, the social distancing measures have been really essential and fairly effective as the data that, NS presented us. But the individualistic culture that we have, I think has really impaired us. I think this pandemic has really reflected cracks in our system and our lack of pragmatism, I think, oftentimes when it comes to dealing with health issues. We oftentimes, I think, have ideologies and particular morals that often overdetermine some of the ways that we respond to some of these things. Our for-profit healthcare system, which I sort of link to some of the very individualistic culture, demands a kind of efficiency that has resulted in really under capacity to deal with this kind of pandemic. In California, we had stockpiles that were amassed in the early 2000s of masks and ventilators and hospitals in a box. And those resources were kind of squandered with, as the 2008-2009 recession hit. So it's meant that we've also had a real patchwork. This individualistic culture has meant that our response has not been organized or centralized, but we've had a patchwork. And so some states still do not have stay-at-home orders today, putting people in those states, in particularly vulnerable positions. Those are also some of the states that have not expanded Medicaid to people, putting those, people who don't have access to healthcare in particularly vulnerable positions. And it's also part of why we don't have a universal healthcare system. So those are some of the things that I've been thinking about. Some interesting things that I'm also kind of just looking towards are, talk of viral passports and sort of new configurations between the state and individuals, but not just individuals, but individuals sort of viral status, which are kind of interesting. And I think things that I'm going to be sort of tracking and paying attention to. Those viral passports are being talked about in Europe, largely, at least that's where I've heard that being talked about more seriously. It's also been interesting to think about changes in work. And obviously, Ines, I really appreciate you highlighting sort of the kinds of jobs that people can do at home, the percentage of total jobs and the kinds of jobs, because it really is more of those who, have maybe advanced degrees or who are earning more money can do that work from home. So will work expectations shift once we've gotten control of this pandemic? Will we allow more, for at least those of us who can participate in, the working from home, will that begin to be more normalized? And then just lastly, before I've got a couple of questions, and I imagine you guys have questions too, so I don't want to dominate, but I also thought a lot about the climate. So there've been a lot of great maps about how emissions have gone down as a consequence of the pandemic and the, staying at home, the social distancing measures. But I've been thinking, and long lamented our lackadaisical response in the United States to climate change, and sort of wondering, will this be kind of a new way of thinking about threat? Will we take other threats seriously, recognizing very much that we maybe didn't take this one as seriously as we should have, and didn't take the threat maybe of pandemics or even epidemics as seriously as we could have? And will we then kind of reframe or think about climate change in new ways, recognizing the incredible impacts that this pandemic has had on everybody's daily lives? So those are just some of the things that I'm thinking about. Lastly, too, just the experiences. We've seen lots of really great stories reported by journalists and others, like what's it like to have COVID? What's it like to live under quarantine? What's it like for healthcare providers who are providing this vital care to folks on the front line? What kinds of worries and fears do they have? Again, those are just some of the things that sociologists of health and illness are thinking about. So Carla, I wanted to bring it back to you. Katie just talked a lot about sort of our advanced understandings of coronaviruses, and that might be, a tool that we could marshal to more effectively develop a vaccine. And wondering if you could take us back to the early 20th century when the Spanish flu was, ravaging populations. And was there a sense then, or maybe, that there were also scientific tools that could be marshaled to deal with the Spanish flu as a threat? I mean, are we kind of being presentist by looking back and thinking, oh, this was a different time. We have such more advanced tools now. And so now we really can address a threat like this. I don't know if there's any reflections that you have on that sort of question or set of issues.
Yeah, I think that's a really good question, because I think, on the verge of, and during World War I, there, at that point in the US and Europe, there was, this feeling that because of the emergence of bacteriology, right, that there was these strides towards understanding infectious disease. And there were a few vaccines developed at that point, rabies, et cetera. So there was this kind of sense that, that the laboratory was going to deliver. And so, but I think that's interesting because, in some ways, one of the, I think, parallels to our own time is that, they really, when the so-called Spanish flu arrived, there was so much uncertainty about what it was and how it worked and how it impacted bodies, because at first people thought it was just a regular flu, and that seemed something that was really familiar. It seemed at first there was, people downplayed its seriousness, and then lots of people started to die very quickly. I mean, that was what was, young people in particular, young adults, I should say, and also those who, it would hit people very quickly. And so there were, a lot of uncertainties surrounding the knowledge of it. And I think what's interesting is that, I think there's, one other parallel to our own time is kind of the confidence that there's emerges at times around this ability to manage, right, these kinds of infectious diseases, when in fact, there's the danger is really present, right? So that kind of the overconfidence in some ways is something that I think can become a real issue. And we saw that, I think, a little bit in 1918. But what's interesting is that, of course, I mean, as you probably know, I mean, it's unclear how many people that pandemic killed. Some people say it's around 50 million people. It's estimated that 1/3 of the world's population was infected at some point. It killed 675,000 Americans. And for something that was that severe, it's really interesting that it's only kind of in the late 20th century, early 21st century, in the past, few decades, that its memory has become so prevalent. And as I said before, it's just really, everywhere you look now are these comparisons to 1918. And I think, in some ways there's some really good ones. Some of them, Rachel, I think you're touching on, and not only this uncertainty about how the disease functioned, but also what to do for people, in the sense that it was just a sort of matter of managing symptoms. And we kind of seem to be in a very similar, in some ways, place as far as that goes. There was also kind of a lack of resources and preparation. That seems to be another, comparison that's often made, because of the fact that most resources were devoted to the war, to the U.S. entry into World War I. The physicians were, some of the considered top physicians were sent overseas, and funding and personnel. And so it's interesting to kind of think about those shortages issues, that those things aren't new. Quarantine, like the debate over whether masks work or not, that was something that was also prevalent in 1918. Also the issue of information and misinformation, because in 1918, the historian John Barry really kind of has been hitting this home a lot lately, which is the issue of telling the truth. And because of the war, the US and Europe actually did not kind of fully come to full disclosure with the populations about how threatening and deadly the flu pandemic was at that point. And so, I mean, another, I think, also important parallel has to do with vulnerable populations. I mean, you guys were talking about that, which is, of course, really important. And, there's a lot, again, the statistics are, and epidemiology on this is a little unclear, but it's really, a lot of historians believe that the death rate, for example, in Africa was much higher. So that colonialism and like the history of the colonies, right, really impacted you know, how people worldwide, right, to think about this as a pandemic, how people worldwide disproportionately had a higher death rate in certain areas because of the colonial history in that. And then also, you know, I think globalization is something a lot of historians point to, in the sense that even, you know, the mass movements of troops and people during World War I, you know, parallels our own kind of age of air travel and travel mechanisms. But you know what, I think the last thing I'll say is that I think in addition to thinking about those parallels, you know, we also kind of need to think about why it was forgotten and then why it's now kind of very useful to us. This, you know, talking about 1918, because you could look at a lot of other history of epidemics. You could look at, you know, cholera epidemics in the US and in Europe in the 19th century. Those have a lot of really important lessons for how societies construct outsiders, especially during a lot of the cholera epidemics. There was a lot of it was seen as being brought by ship by foreigners, quote foreigners, and a lot of immigrants were often blamed, right, for the arrival of these epidemics. So that, you know, there are other, I think Merritt of course pointed to the HIV/AIDS epidemic, pandemic, I should say, and vulnerable populations and those kind of comparisons as well. And you know, historians were even pointing to the medieval, to the plague, right, to kind of look at the history of quarantine. So I do think, you know, it seems like it's the most recent comparison, and I think it is, you know, very, in some ways very useful, but I think we could even look at further back and look at others to kind of think about questions we should be asking ourselves in this time. So
can I jump in there to just sort of pick up on what you were saying, Carla, and respond to some of Rachel's comments? I think, you know, the comparisons to 1918 are very interesting, and I will admit that I, like, 6 weeks ago, I immediately bought every book I could buy about that flu. But also the most glaring difference is living in the 21st century and in the age of technology. We're even now different from 10 years ago with the last H1N1 outbreak that we're able to do this, right? And so I want to go back to what Rachel was saying about South Korea, because I've also been paying attention to South Korea as a country with a more socialized healthcare system, et cetera. But what's happening over there is a very, I think, very scary level of surveillance. And if we look at histories of social activism and social movements in this country, especially over the last 100 years, we know that there has been an intense amount of social surveillance on activist groups. And a lot of the sort of suggestions that are coming forward are the ideas of putting geo-trackers on our phones. And this will be something that we should resist, because it will be a very slippery slope to surveilling activist movements. And this is a time that is both a devastating historical moment and a moment from which we can expect new worlds and new forms of coalition and new forms of activism. But this kind of geo-tracking surveillance, which currently in Korea, which is a very homophobic society, is being used to dissuade people from congregating in gay clubs, for example, from having other forms of social context, knowing that they are now surveilled by their government. And I think, so related to that, this whole concept of big data, that both repeats, there's a lot about big data, this is maybe for another time, that shows how in our social engagements that happen largely digitally, we are sort of only reflected back to us the things that we already know about ourselves, because the algorithms work to solidify ideas of sameness rather than engage ideas of difference, which are central to coalitional work. And so in that way, I want to just add two other things. One, even the ACA is a right, it's access to health insurance, which is not access to healthcare. And so I can say this as someone with a great middle class, well-paying professional class job with healthcare. It doesn't mean that with health insurance, it doesn't mean that I have the best access to healthcare. And I think related to that, I've also been paying attention to this question of climate change and how will this moment, I live in LA where I can suddenly see mountain ranges that I couldn't see for the last 4 years that I've been living here, right? But having spent the fall reading deep into climate change and waking up with nightmares every night, what I know is that the people who are most vulnerable to climate change and to the effects of climate change are also the most vulnerable to this virus. So how is this moment being sort of utilized as a moment to say, like, look, here's how we need to change climate, but also still not protecting the most vulnerable populations and communities in our society. But I think also a good moment to look for, speaking of the economy, and maybe this is something that Inez can answer, is like, what does a green stimulus package look like? And how does that actually work in tandem with all of these questions?
Yeah, those are a lot of really great questions, Merid, and certainly probably ones that maybe we should take up in another panel gathering where we can kind of think about, you know, issues around climate, issues around maybe surveillance and surveillance technologies and how we're using those, and some of the promises and pitfalls of those, and again, the ways in which they are both helpful and potentially harmful. You know, are some really great questions. Ines, I don't know if you had just a quick follow-up that you wanted to chime in.
Very quickly to just respond to Meredith's point. I think we should take this opportunity. I love the points regarding climate change, and also making sure we don't turn this into a surveillance state. So not everybody's doing this, right? So South Korea and Germany definitely have cultural differences, but one thing that's common about what they've done is that they've also had much more extensive testing. But I think we should take this opportunity it is a kind of a turning point to kind of say, well, let's make sure the stimulus package is green. Let's make this an opportunity for more effective climate change. And just quickly also circling back to Katie's point, I think it's so just about the vaccine. I think it's so important that not just during pandemics, but on a regular basis, they be given the economic incentive to, you know, for research and development into vaccines. But what's of course tricky, you know, not just through patent protection and other means, but also the tricky part is also making sure it's affordable and accessible to everybody at the same time, not just for equity reasons, but because of the huge negative externalities associated with not being vaccinated. And so, I'll end it there and just say thank you very much, Rachel, for organizing this panel.
Yeah. So I'll go ahead and wrap up. I want to thank all of our panelists, Dr. Carla Biddle, Dr. Merid Sullivan, Dr. Ines Kelly, Dr. Katie Mizakis. And just to put in a very quick plug for the Health and Society program. So in fall 2019, LMU launched a new minor in Health and Society to really explore the social foundations of health, but also integrating some of the basic science that we need to kind of understand some of these pressing health problems that we're dealing with today, that we've dealt with in the past, that are, again, maybe things that we've long dealt with that are being sort of reconfigured or re-understood or re-narrated today. So folks who are interested, we've got a website. I'm not sure what it is because I offhand, but you can Google LMU Health and Society and it should come up right away as the first hit, but it describes the minor, what's required. So a number of us on this panel are faculty teaching in the minor, and we're really excited that it's been launched at LMU to address these really interesting health questions from a very interdisciplinary set of lenses. So thank you all for joining us today. This has been great.